Okay, we're going to get rolling. So good evening, everyone. Welcome to the MyCP Webinar series, which is a set of presentations aimed at the community about research going on in the Cerebral Palsy Research Network. Tonight, I feel we're very privileged to have Dr. Unni Narayanan, who's going to talk to us about whether or not we can make patient-reported outcome measures useful to patients and parents. I am Paul Gross. I'm the chairman and founder of the Cerebral Palsy Research Network, and Dr. Narayanan is actually on the executive committee as well. I'm going to start by taking us through just a few quick updates on CPRN and MyCP. I do this every time, so if you've been participating in the series, you can sort of tune out for about 5 minutes, and then we'll turn it over to Dr. Narayanan to talk about his research. So the CPRN was founded with a mission to improve outcomes that people with CP value most through high-quality clinical research and quality improvement initiatives. People with cerebral palsy value most is underlined because in our first 2 years of forming, we actually pulled together a community-oriented process to, pardon me, I'm just going to quickly mute everyone. So we conducted a community-oriented research process to find out which topics, which things people wanted to see research most, and that actually drives the work of CPRN. So CPRN conceptually can be hard to wrap your arms around. So what it really is a collection of institutions, of clinicians, clinician researchers, therapists, patient advocates that are all working to conduct research to improve outcomes for people with cerebral palsy. Physically, besides where each of those people are located, it is a data coordinating center, which we refer to as the DCC, and that is hosted at the University of Utah's Population Health Sciences Department. We have two main pieces of infrastructure that we use to sort of accelerate research. One is a clinical registry, and a clinical registry is just a database that captures characteristics of patients, people as they're coming through the hospital, interventions such as surgeries or injections or medications, and then outcomes. And those can be either clinical outcomes, how far does this joint move, or patient-reported outcomes. Am I accomplishing the activities of daily living the way I set out to accomplish them? And this is all built into the electronic medical record, and that's a key unique thing that CPRN does. So as the physician is interacting with you, they're capturing data for their note, and that data is also used for research. The second piece of infrastructure is another registry, another database, and we call that the community registry. And that is for members of the community, whether or not they're a patient at any given time. It's both children and adults, and it allows us to follow people long term. The community registry can function as a way to conduct research about things that you wouldn't talk about during the course of a clinic visit. And also provides a contact registry for people who want to potentially participate in research. And the community registry is hosted at MyCP, or My Cerebral Palsy, which is basically a CPRN-owned web property. It's a web portal that we operate to facilitate engagement of clinicians and the members of the community in research. So the portal offers a few things. It allows you to participate in the community registry via surveys. It allows you to participate in discussions about research. So there's a forum, and there are lots of different discussions that come up about people's experience, and we try to provide what is the most sort of evidence-based treatments and for questions that come up and what research needs to be conducted. It provides news about CPRN studies, and then we're starting to build a set of tools to enhance care. And what Dr. Narayanan is going to talk about tonight is really a tool that we have our eyes set on, and we've been working with him to actually build into MyCP. And any of you, if you're not part of it, can always sign up at mycp.org. This is just to give you an idea of some of our activities. We're You know, when we started 5 years ago, we had no research. We built this infrastructure. We've reached out and gotten so far 28 sites signed up to participate, and we're trying to generate lots of research. And it starts with the left side of the funnel where ideas are kicked around and people collaborate, and then they move through a process of review and approval, submission for grant opportunities, and then if they get funded, they move on to actually get executed as studies. Some of them are long-term, like the community registry, and some are, you know, single studies that'll be completed in a year, 3 years, 5 years. And so we have a lot of activity going on. And then ultimately, we try to publish our work, and then we try to take the evidence that we've generated and evidence that's in the field and take it back around into the clinic and use it to implement findings so that we're in a sort of continuous improvement process. So this is just a little bit of a snapshot of part of North America, and you can see the green pins are where the registry is actually up and running and patients are being enrolled in the clinical environment. The yellow pins are sites that are doing the work to prepare the registry to integrate it into the electronic medical record. The red dots are sites that are kind of going through some of their compliance and their IT discussions to get ready to prepare the registry. And then the blue pins are sites that have expressed a desire to come on board, and they're kind of working through our process for onboarding a new site. So that's where it is. If you want to learn about the specific sites, you can go to cprn.org, where we keep that up to date. And so without further ado, I'd really like to, I'm proud to introduce and ready to turn it over to Dr. Unni Narayanan, who has a lot of degrees, and I've been referring to him as MD, but he's actually an MBBS, and he can probably explain that one to us. And he is a pediatric orthopedic surgeon at SickKids in Toronto, and an associate professor of the Department of Surgery at the University of Toronto, as well as a senior scientist at the Bloorview Research Institute. So that's their rehabilitation hospital. And he was a past president of the American Academy for Cerebral Palsy and Developmental Medicine, which is the professional society that organizes all the clinicians and therapists that treat, and researchers that treat people with cerebral palsy. And he's been a member of the executive committee of CPRN, so he helps steers the direction of it since its founding. And so with that, I'd like to turn it over to Unni. Unni, why don't you see if you can, there he is in his office. Looks like you're at work, Unni, you're working late. We can't hear you. So let's see if you're muted. Oh, let me unmute you, because I muted everybody. I can fix that, I know I can. We have the technology. Just need to find Unni on the list. There you are. Oh, you're unmuted, go ahead.
Excellent, thank you, Paul. Since that photograph was taken, I've lost my beard and I've been promoted to full professor. That's been a couple of years.
Well, you know, your website is not up to date, so no, I will update that though.
I'm kidding completely, of course. The MBBS stands for Bachelor of Medicine and Bachelor of Surgery, which is the typical degree in medical degree in India or the British Commonwealth. I mean, that's the degree that you get rather than an MD. It's the same as the MD. Thank you for the introduction, Paul, and thank you for this opportunity to share something that I'm very passionate about, and I'm really delighted to be able to engage with the community and hope that there'll be interactions that stem from this that I'm looking forward to. So, patient-reported outcome measures, what's in it for patients and parents is sort of the title of this particular talk. I'm a pediatric orthopedic surgeon. I look after children with cerebral palsy. That's a major focus of my clinical practice. I subject them to a large number of interventions, and I'm interested in knowing whether I make a difference to the lives of these children. If you're talking about patient-reported outcomes, we need to start by asking the question, you know, what we mean by outcomes in the first place. So outcomes are what happens after some treatment or after the passage of time. They can be desirable, things that we want to happen, the reasons for which we having this treatment in the first place. They can be undesirable, things that we don't want to happen. They can be things like complications or side effects or adverse events. And we can think of outcomes both in the early or short term, in the medium term, and in the late term. What is a successful outcome? I think we can all agree that it's one where the goal for which that treatment was intended was achieved. That's pretty straightforward. And that goal can be the patient's goals. This could be a child's goals. It could be the parent's goals. It could be both their goals. It could be my goals as a clinician. But it's important to make these distinctions and to understand, whose goals matter the most. And clearly, it's hard to argue that it is the person with CP who is undergoing this intervention whose goals that matters the most. And when you're talking about children who may not be able to tell us what their goals are, we rely on their parents. And sometimes it's both their goals, and those can be divergent or convergent. And outcomes measurement or outcomes research is the science of measuring the effectiveness or success of our treatments. You're probably all familiar with the term evidence-based medicine. This is defined by this very pithy statement, which says, it's the use of the current best evidence in order to make decisions about the care of individual patients, which suggests that, there is good evidence, and for different individual patients, there may be slightly different decisions that are made. And the spirit of evidence-based medicine requires one to combine, having difficulty advancing the slide, the best available evidence generated from high-quality research. So the best science there is to tell us that treatment A is better than treatment B. But we've got to combine that with clinical expertise and judgment that's derived from a clinician's experience and practice with the particular population. That obviously has a role to play. And often forgotten is incorporating patient preferences, understanding what's important to them, what their priorities and goals are, and making sure that the evidence that we're applying is indeed in order to achieve what those priorities and goals might be. So there's been, over the last 2 or 3 decades, an evolution in this notion of patient-centered care. We are interested, obviously, in the patient's perspectives, and the movement of outcomes research came about to sort out really what works in medicine, to learn how to make clinical decisions that reflect more truly the needs and wants of individual patients. In other words, the success of our treatments really should be judged using meaningful outcome measures that reflect the goals and expectations of individual patients. And if they have to reflect their goals and expectations, these have to be patient reported. So outcome measures not filled by me, the clinician or the doctor or the therapist, because I'm biased and I might think that this has done the patient some good, and it might have, but we really want to know from the patient or their parents whether the outcomes that they wanted were actually achieved. So why is this important, cerebral palsy? Well, cerebral palsy is a chronic condition, and it's by far the most common cause of childhood onset chronic disability. The impact is lifelong. It affects not only the child, who ultimately becomes an adult with cerebral palsy, but also to the parent, to the caregiver, the family at large, and perhaps to the healthcare system as well. Many of these children and subsequently adults are subject to major interventions that are resource intensive, they're expensive and associated with complications and so on. And we really need to know, are these making a difference, a meaningful difference to the lives of these kids and adults? How successful are these treatments? Do patients and parents actually get what they want? And very early in my practice, one of my patients' mothers told me this: no one asks me what might make life better for all of us. This and lots of other experiences got me to embark on a research program where I was interested in understanding, what is the lived experience of children with cerebral palsy or parents who take care of kids with cerebral palsy, and how can that understanding of their lived experience allow us to better elicit their priorities and use that information to understand what sort of treatments we can do, we can offer them to address those priorities. This work led to a framework of outcomes evaluation that I call the priority framework, that has at the center the child or a caregiver of a child with cerebral palsy, for example. It could be other things, but in this case, we're sticking to cerebral palsy. You know, what is their lived experience? And through qualitative research, trying to explore and understand what their concerns, desires, needs, and expectations or what their priorities are that arises from what their daily life experiences are. And if we understand that, you know, can we understand what their goals might be? If we want to explore this, we have to acknowledge that there may be different perspectives. There's a perspective of the parents, there's a perspective of the child. Whenever that's available, we should certainly attempt to access that. There is the perspective of the family, and then there's the perspective of the clinician or society at large. And you can see that these perspectives might overlap, but they may also diverge. What may be good for the child may not be good for the sibling. What's good for the parent may not be so good for the child. And that's the reality. And we need to acknowledge these different perspectives. My contention is that until we understand what the priorities and goals of children with CP or their parents are, how can we really address these priorities with the kinds of interventions that can address these priorities? Well, those interventions typically as a clinician might be surgical or medical or therapies of different kinds, but we can think of interventions on a much larger scale. They can be legislation and policies, programs and services, technology, architecture, devices and equipment, a lot of things that can address the variety of priorities that a person with cerebral palsy might have. Well, if we come up with these interventions, we need to know whether they actually work. How do we do that? Well, we assess them with clinical trials or cohort studies or research programs or program evaluations. That's fine, but we still have to have some sort of yardstick or a measurement or a metric by which we can say, you know, program A is better than program B, or surgery A is better than surgery B. And what is that metric? Well, for that we need outcomes. These are what measure or define success, and these outcome measures, if success of an intervention is defined by whether or not that intervention achieved these priorities and goals, then it stands to reason that the outcome measure that we use to measure success must include those or embed within them those priorities and goals as well. So it really comes back to an understanding of these, which we hadn't done a very good job of in the past, and has been a major focus of my research program. Through that research program and using that framework, we came up with two priority-based patient-reported outcome measures. One is the Caregiver Priorities and Child Health Index of Life with Disabilities, or the CPCHILD, which was intended for the severe end of the spectrum of persons with cerebral palsy. These are children, or subsequently adults, who rely on a wheelchair for their mobility and on a caregiver for most of their activities of daily living. For many of these, for these children, we have no choice but to access the perspective of their parents, but in some instances, in a minority of instances, we can access children's perspectives as well. And the CPCHILD was derived from interviews of parents, healthcare professionals with expertise with this population, from the literature. And the culmination of that work led to a 37-item questionnaire across 6 different domains that I'll explain in a minute. These domains include items on personal care and activities of daily living, items relating to positioning, transferring, and mobility, comfort, emotions, and behavior, communication, social interaction, items relating to the health of the child, and quality of life. And for all the items in the main body of the questionnaire, there's another section to determine how important these items are in its contribution to the child's quality of life. So that's the CPCHILD questionnaire. Its corollary for children who are ambulatory is called the GOAL questionnaire. The CPCHILD questionnaire is really for the severe end of the spectrum. It's been shown to be reliable and valid. It's being used worldwide. It's available in 18 languages. And it's being used to evaluate many interventions that are used for this particular population. Spinal operations to correct scoliosis, hip interventions for hip dislocations, intrathecal baclofen pump, Botox, gastrointestinal or feeding interventions, seizure management, deep brain stimulation, effects of complex care management, and so on. The GATE Outcomes Assessment List, or the GOAL questionnaire, was developed for the ambulatory spectrum of cerebral palsy, for those kids for whom the interventions are related to GATE-related outcomes. This outcome measure has 49 items distributed over 7 domains. The first being things that are required to maximize independence and perform activities of daily living. A second domain is on gait function and mobility. A third on comfort and endurance, or pain and fatigue. Physical activities, sports and recreation. An entire section on what the gait looks like, or the appearance. The use of braces and walking aids, and finally on body image and self-esteem. And what's unique about this questionnaire is for each item, again, there's a question whether making a change in an item is an important goal for the respondent who completes that particular questionnaire. So patient-reported outcome measures, or PROMs in general, are considered really the preferred way to measure outcomes of effectiveness or outcomes of success. That really should be the way we measure our outcomes. However, just because it's patient-reported doesn't make it a good patient-reported outcome measure. A good one must be relevant and important to patients and parents, and therefore, in the way they were developed, we need to make sure we incorporated their priorities. In our case, we used the priority framework to do that for the CPCHILD and the GOAL. The content must be derived from and include their perspectives. The completion of patient-reported outcome measures, we have to acknowledge, impose a burden on the respondent. That takes 15 minutes or 20 minutes to complete this. And I justify this because I say that this is what's necessary to know whether our treatments are actually working. And in the context of clinical research, we can justify that, but we really have to ask this question: what's in it for the patient or the parent? When they complete these questionnaires, that doesn't alter the outcome that they've had. If they've had a treatment, the outcome is whatever it is. And just because they complete this questionnaire that takes about 20 minutes, we're relying on their goodwill to give us this information. And they understand perhaps that this is necessary to generate evidence that particular treatments are better than other treatments. But at the end of the day, there really is nothing in it for them in the way they complete them. And that's a problem. So the question really is, can we make patient-reported outcome measures useful to patients and parents? And one potential way is, can these patient-reported outcome measures be used to actually guide decision-making, for example, in cerebral palsy? So what do we mean by decision-making? Well, we know that children with CP are often candidates for major interventions, and the goals for these interventions can be quite diverse. So for ambulatory kids, it could be goals related to improving gait, and that could mean different things for different children or for different parents. It could be goals related to optimizing their function and their ability to participate in things that they want to do, and or maximizing their independence. For children at the more severe end of the spectrum of cerebral palsy, it could be about preventing pain or relieving pain. It could be about improving their health. It could be about helping caregivers or parents ease the caregiving burden, because it can be quite a challenge to look after some of these children. And it could be about optimizing the quality of life of these children. Individual patients and their parents may have different goals from other patients and parents, and indeed, individual patients might have different goals from their own parents. And there are different treatment approaches for the same goals. And each treatment approach might have its own sets of pros and cons, which different patients or different parents might weigh those pros and cons quite differently based on their own values and their own preferences. And we need to take all of that into consideration. And the bottom line is that making decisions about treatment is really quite difficult for patients and parents, and can be a challenge even for us as clinicians when you're dealing with all these complexities. Now, the CPCHILD and the GOLD questionnaire are two patient priority informed patient-reported outcome measures. So we have embedded in them items that we know are important to this particular population because they were derived from this population. But what's unique about these measures is that not only do they document how well a child or a parent is doing in a particular item, but it also measures the perceived importance of that item, and whether making a change in each of those items is an important goal for improvement by asking this question. Okay, so is making a change in this particular item an important goal for you? And the question is, does the addition of that particular question, does that provide some clinical value either for the patients or the parents or for the clinicians? And can that have a positive impact on decision-making or shared decision-making? So let me give you an example. This is, half of a page of a paper version of the CPCHILD on section 1, which deals with items on personal care and activities of daily living. And the questions go, during the past 2 weeks, how difficult was the following? And there's about 9 items in this on this particular page. There's an item here on feeding, there's an item on oral hygiene, on bathing and washing, toileting activities. And in this case, the parent is supposed to respond, how easy or difficult is accomplishing each of these activities as it's usually performed? Is it not possible or else almost impossible or no problem at all? In this case, it's slightly difficult, feeding is slightly difficult. Oral hygiene is quite easy, bathing and washing is difficult, and toileting activities is very difficult. But there's some additional information as well. How much assistance is required to achieve that task? So it's slightly difficult and it requires total assistance. And then there's a third part here. Is making an improvement in this particular item an important goal for the respondent? In other words, is feeding, making it less difficult, or making the amount of assistance required to achieve it, so moving the scores more to the right in the degree of difficulty and the level of assistance required, is that an important goal? And in this case, the parent has said yes. Let's take a section from the GOLD questionnaire. In the first section, which is on activities of daily living and things related to independence, again, during the past 4 weeks, we ask the respondent, it could be the child or the parent, how easy or difficult it is to perform a particular task. In this case, getting in and out of bed, is it extremely difficult to no problem at all? The child responds, it's very easy. The level of assistance required was moderate assistance, so they weren't doing it completely independently. And in this case, they rated this as an important goal for them to improve. So either they wanted to make it no problem at all, or they wanted to become more independent to achieve this particular task. So this additional feature, we want to test whether that actually creates any value for patients and parents. And if there is some value, that might provide them an incentive to complete these questionnaires beyond just doing it for the purpose of research. So the project that we're doing with CPRN sites is a 2-part project. The first one is to develop an electronic web-based version of these questionnaires, or the electronic patient-reported outcome measures, which on completion will generate a summary report for the patient or the parent, which not only includes the scores, which you could argue have very little significance, but it also lists all the items that were identified as important goals to address within each of those domains. And of course, we need to make sure we have the software to ensure the compatibility across a variety of platforms and electronic health record systems to capture this information. So let's say a child and a parent complete the GOLD questionnaire, and on completion they submit. So there's an electronic version of this, and on completion there's a summary report that has the scores for each of the 7 sections or domains. So for activities of daily living, The child scored a score of 76.5 from a score of 0 to 100, and so on for each of the domains, and a total score of 64. Now, they could present these scores on graphically to show what is the performance of this particular child compared to other children with the same age or the same functional level. So if the child, in this case, functioning at a GMFCS level 1, functions at the 29th percentile compared to all other children at GMFCS level 1, is that useful? But more importantly, for each of the domains, it also lists which items, in this case, the child identified was important goals for her to improve. And you would have a separate one for all the important goals that the parent identified were important. Now, once they generate this list, they can then present this to their clinician and say to their doctor or the therapist, say, all right, these are my goals. You made me fill out this questionnaire. Here are my goals. Here are my scores. What are you going to do about this? And me as a clinician looking at this and say, okay, in the context of a 20-minute or a half an hour or 1 hour appointment, is this an efficient way to find out what the goals of my patients might be? And how then can I tailor the discussion of that particular clinic visit to see how we can address these goals, what treatments we should consider that will address these goals, while we're actually measuring how they're doing in each of these areas as well. And so the question then becomes, will completion of this type of electronic patient report outcome measure prior to clinic visit and generating this report provide value for patients? So can it empower patients and parents to present these goals to clinicians? And for clinicians, does this provide them a systematic, comprehensive method to elicit these goals, which can then guide shared decision-making, while also evaluating the outcomes for research and routine clinical care? Because presumably, if they recommend a treatment, then a year later when these are being elicited again, we can see whether they made improvements. So the first aim is to develop that electronic version, and we're well on our way to doing that, working with certain health outcomes platform providers. And the second aim is then to pilot test these in a variety of clinical settings: orthopedic surgery for the hip, the spine, for gait-related issues, neurosurgery, for SDR, back and pumps, complex care and development pediatrics, for feeding interventions like G-tubes or GJ tubes or fundoplications, also seizure management. And we then want to know from patients or parents and from clinicians, what the perceived value of these EPROMs might be. So part of that study is to look at patients and parents who've had surgery in the last 2 years in all these areas, in multiple centers in Toronto, in Melbourne, Australia, and in various cities in the United States. And most importantly, we have an opportunity to go to the community through MyCP or CP Now to ask them to provide us information about this. And we'll ask them in the past, do they, when they had these interventions or their children were subject to these interventions, what were their goals? What were the goals that they had? Were these goals actually discussed? How easy or difficult was decision-making related to these goals? And if they had the CPCHILD and the E goal at their disposal, would that have helped with these discussions? So that's one part of the study. And the second part of the study, to go to similar participants who are about to have these interventions, who are candidates for these variety of interventions. They will complete the electronic patient report outcome measure prior to a clinic visit with their clinician to discuss these interventions. And then after that visit, they'll complete the electronic version of the patient report outcome measure. The EPROM summary report will be generated, which we provided both the patient and the parent and to the clinician. And at the end of the appointment, both the patients and parents or the clinicians will be surveyed about the value of the EPROM and the summary report to see if for the patients and parents, did it allow them to elicit the goals that were most important to them, and did that help with the discussion with the clinician? And for clinicians, did that help with decision making? And how much did this process contribute to the success or not of the decision making process? So in this pilot study, we want to know that can prompts be designed to elicit patient goals so that they can be used not only to be used as outcome measures, but also to elicit their priorities and goals, which can then allow them to influence decision-making. For clinicians, it's a very efficient and comprehensive way to identify patient and parent priorities, providing them an opportunity and indeed a responsibility to respond to these priorities. And can we show that the value of such a PROM extends beyond its utility just to track outcomes? Things like facilitating decisions about whether and when to intervene, guide the choice of interventions tailored to the goals, managing expectations. You know, some expectations may be realistic, some expectations may suggest you don't need operations for that, but other forms of treatment improve the informed consent process and enhance shared decision making. And ultimately, this is another form of personalized or precision medicine, not just looking at the genetics, but also looking at personal or patient preferences. This way we can justify incorporating these EPROMs in our electronic health records to enhance decision-making, obviously to collect patient outcomes for research and for quality initiatives and to track clinical outcomes. And this might serve as a template for other electronic patient-reported outcome measures in patient-oriented research. Lots of investigators, Paul Gross and Michelle Schusterman, are both parents of children with cerebral palsy, and their input is invaluable. My clinician investigators include development pediatricians in Canada, in the United States, orthopedic surgeons in Australia, in Canada, in the United States, neurosurgeons in Toronto and the US, physiotherapists, and even bioinformatics specialists. And all of this is being run out of our lab here at the Hospital Sick Children in Toronto. So I'll stop right there and answer any questions and open it up for discussion.
Great. Well, thank you so much, Unni. Let me, I think people should be able to unmute themselves with the tool. We'll see if we have too much collision. If so, I will go to a chat-based Q&A. But I just want to ask you to do one thing, if you would. I think shared decision-making is not necessarily an intuitive thing. Could you say what shared decision-making, if you achieve it, means and how it's different from the way decisions potentially get made when there's not shared decision-making?
Yeah. Yes, I think that's an important oversight on my part. You know, in a typical scenario, a patient or a parent with a patient presents to a clinician and presents with a certain list of problems. And the doctor does some investigations and says, all right, you know, based on these investigations, we think the reason why you have these particular problems are X, Y, and Z. We do these tests. And if these problems are really troublesome for you, or might become troubles for you in the future, here are some treatment options. Treatment option A has these advantages and disadvantages. It might address these problems, but it may not address these problems. Treatment B might address another set of problems, but may not be good for these problems, or may have these side effects, or may be associated with these particular complications. And if we're doing our job well, as a clinician, I should share these choices with parents and patients after I elicit their problems and what their goals might be, share these pros and cons of these different treatment approaches, and together help them make a choice about which treatment or treatment options would best meet their goals and priorities. And given the same set of problems, two patients or two different families might make very different choices about treatment A versus treatment B. You know, sometimes it's very crystal clear that there's only one treatment. There's only one gold standard. But for many people, each with their pros and cons, and this is where shared decision-making, where we provide an opportunity for patients and parents to share with us what their choices might be, so that we can help them make the decisions that are best for them, is what shared decision making is all about.
Great. Thank you for that definition, Unni. I think that really helps. So let's open it up to questions. I'm going to let you just unmute yourself and ask your question. I'm sure we might have a little collision, but we'll see how it goes. And if not, there's some questions.
My screen, Paul, or should I leave it up?
I think you can leave it up. I think it's actually, why don't you just go to people seeing your smiling visage for Q&A. I think that would be fine.
Okay.
There we go. Okay. So I will say, nobody's unmuted to ask a question. I have seen some questions. One person asked for your slides, and I said that this recorded presentation would be available. I don't know if you'd be comfortable sharing your slides. I could distribute them or put them in a place if you're comfortable with that.
Oh, I'd be happy to. I can send you a PDF, which is a smaller, a less easily distributable. I'd be happy to do that. Yes.
That'd be great. So Jan, there's your answer to your question, and I'll let people know when I email people about the recording where those can be reached. So let's see. Go ahead.
Hi, my name is Sam, and Professor Unni, that was a good talk. Thank you so much. You benefited a lot. I'm a physiotherapist, and I work at Christian Medical College, Vellore. Is the pilot study still on? Are you looking at any other international sites to implement patient-oriented outcomes?
Thank you for your question, Samuel. We got funded through the Canadian Institute of Health Research this spring, and because of COVID, we're sort of delayed. And we are constantly being asked by additional sites whether they can participate as well. The challenge, of course, will be, we've got a certain fixed amount of funding that it's difficult for us to expand it to more sites than was originally planned. However, this isn't a very expensive pilot study to do, and there may be opportunities to collaborate. And if you want to email me, I'd be more than happy to explore whether that is possible. Now, you're in Vellore. I don't have a Tamil version of the CPCHILD or the goal, but that's another conversation. I have in other languages, people are working on a Hindi version, but Vellore, for those of you who don't know, is in Tamil Nadu, which is in the southern part of India, not far from where I was born and brought up in Madras, which is on the southeast coast. And I know CMC Vellore very well, having visited that. So, but please email me, and I'd be happy to explore whether we can do that.
Sure, Professor, I will. Thank you so much. Thank you.
Great. Thank you, Samuel. I'm going to go by raised hands, which is always a good idea. I couldn't see the option, so I was worried that it wasn't there. So Poonam, I know you've got the joy of meeting Dr. Narayanan face-to-face, but you have a question, fire away.
Yes. So thank you so much, Dr. Narayanan. This is a very heartening to see that this questionnaire is available now, which wasn't the case when our son was growing up. So my question is, so I'm looking back and thinking, if we had this questionnaire then, the biggest thing that we faced was we were so naive when we were given the diagnosis. And as my son was growing up, we didn't even know what to expect. And if I look back and I say, oh, at a certain point in time, like these questions sound like they are more like kind of in the present, applicable in the present situation. But if I look back, I feel like I would have liked to know what to expect in future. And that's where I think that would have been helpful for me to say, this is what I want him to do like 5 years from now or 10 years from now. And luckily we have another child who's typically developing. So I always use her as a benchmark within our family. So I'll let you kind of I don't know if I've clearly articulated, but I feel like there's something that I would have wanted more to be able to express what my goal is and the long-term impact.
Yeah. Thank you for that question, Poonam. It's questions like this that I think are really important for us as clinicians to really understand what it might be to be in the shoes of someone like yourself, because that's, I don't have that personal experience. So really, this is very important. And what I think you're articulating is that, the two questionnaires that I showed you are just, two examples, and who each one of those might be applicable to and when in their life it might be applicable to are quite different questions. I think what you're alluding to is that very early in the course of your child's life, when a diagnosis is first being shared, for most parents, there is the uncertainty about what that means and what the future holds for them. That's a whole different set of circumstances than, 2, 3, 4, 5 years down the road, when it becomes clearer about what the prognosis might be in some instances, or there is a better understanding perhaps of what that course might be for an individual child. And it's at that time when you're actually considering, or a parent is considering, okay, here are the issues that my child is experiencing, here are the treatment options, and there are so many different kinds of, which one should I be choosing, A versus B, and so on. It's under those circumstances that these patient-reported outcome measures can apply. So these outcome measures were not intended to, and therefore will not be able to answer the question that you posed, which is to say, okay, by completing this when your child was a year or 2 years of age, it wouldn't have been of any value at that point. It would not have been applicable. So I think that we need to think about surveys or questionnaires for that, for that stage, if you will, for very different reasons. And that is more about how best can we prognosticate and share with you what we understand might be the life course of a child given a certain set of conditions and investigations. A totally different objective to what these outcome measures can do.
Thank you.
One thing I would just add, Poonam, I don't know if you saw the interview we did with Lily Collison. We think resources like CPNow's CP Toolkit as a starting point, books like Lily Collison's, spastic diplegia, bilateral cerebral palsy. These are great resources, and I think a lot of people would benefit from kind of a roadmap to understand. And we've been talking about projects where we could try to understand as much about initial injuries and really be able to project what the possibilities might be. So there's a lot of work to be able to do here in this regard. But thank you for your question. Heather Hancock had a question. Heather, you want to fire away?
Sure. Thank you, Professor, for your presentation. It was very encouraging to see the work that you're doing in getting the different points of view as to outcomes and what's important to patients versus parents versus clinicians. I could only wish that happened when I was a child. I have spastic diplegia and I'm 52, living in rural Saskatchewan, so hello from the prairies. My question is I know you're a pediatric orthopedic surgeon. There is a lack of support for adults with CP in our country specifically. And it's very hard to get past your GP who knows nothing. And is there any future consideration for this kind of a a set of questionnaires to be available to GPs or to other doctors dealing with patients in isolation in their communities?
Yes, I think that's a very good question, and I don't have to tell you that adults with CP around the world have difficulty accessing care that's specific to their needs because there's a lack of an understanding by GPs and even various subspecialists who don't have the experience or the expertise for what is something that had its onset at childhood. To answer your question specifically, with CPRN, there is a group very interested in adult CP-related issues. They have their own interest in outcome measures that are important and pertinent to adults with cerebral palsy. Some of the measures that we've developed, the CPCHILD, for example, by definition, was only validated up to 19. There's a group in the Netherlands that has adapted the CPCHILD, working with us to form the adult version of the CPCHILD for the most severe end of the spectrum. So those, but the same concepts of trying to capture the issues that are important to the population. Once we can establish that those measures do that well, then doing it with this particular design might be helpful, but that remains to be seen. It still doesn't address the question, okay, even with that information, what is the GP going to do with that information? We still need to educate clinicians in the adult world to provide or to take an interest in providing the services or health-related services needed by adults with CP.
Yeah.
And Unni, I'm going to add to that the adult questionnaire that's been developed by the adult study group that runs in the MyCP community registry, there is a discussion about taking that and making it a similar kind of tool, trying to validate that and whatnot, and certainly use it to guide interactions with clinicians, because it's very good at tracking decline and understanding where pain is, where issues are. And so there is an effort looking at Dr. Narayan's body of work and looking at that body of work and seeing if it could be validated as a measure for that, as opposed to just a primary research item to get cross-section of adults with CP. Let me turn it to Amber Gorman.
Hi. My question is, how do you plan on educating the medical community about shared decision making so that, I mean, I think this is great. I just know it takes time for all of that to come down the pipe, so to speak. And, you know, people are always resistant to change. And so what do you think is going to be the best way to do that so that we get these better outcomes and people are on board that way?
Thank you for that question, Amber. I think there are two ways. One is by shaming and naming them. You know, if we can, one of the studies that we're planning to do is to actually measure the quality of decision-making for a person with cerebral palsy in various clinical settings. That's actually a CPRN sponsored study that we're proposing right now as a way to demonstrate what we think is happening, which illustrates what you said. That is that currently we don't do a good job of doing shared decision making. So there are ways of measuring that. So this is what I meant by, you know, then if we publish that will shame all of us into saying we need to do something about it. Then the second way is with tools like what I just presented, making it easier to facilitate shared decision making, where we can actually elicit the goals. So that makes my job easier, if you will, but also empowering patients who complete this or parents who complete this. You know, they can then go to the doctor and say, these are my goals. What are you going to do about them? Now, in a way that previously perhaps they couldn't do because they didn't quite think about it that way. Here's a way for them to actually do that. And hopefully that will also trigger and provide the clinicians the necessary impetus, if you will, to listen to patients and say, okay, I have to respond to these questions, and facilitate that process. So you're right, it is a slow process that first of all requires us to quantify that there's a problem, and we can do that, and then come up with ways to make it less of a problem like we're proposing.
Okay, and then I'd like to piggyback that with, if you have two people with the same GFMC level, there might be some commonalities, but there's also very unique, I mean, we're all individuals, so there'd be unique things that are different. So what's going to be this assessment helps that, but for lack of a better word, it's not foolproof, right, in being able to identify that. I mean, because, you know, I have spastic diplegia too, but I probably look very different than, I'm sorry, I don't remember the person that just asked the question, but, you know, we have the same diagnosis. I don't know if we have the same GFMC level, but we have the same diagnoses. So how would this questionnaire be able to best, I'm not quite sure.
I understand your question.
Okay. Okay, thank you.
And that's exactly what this question is about. It is recognizing that given the same diagnosis, I mean, we know cerebral palsy is such a heterogeneous, you know, diagnosis, if you will. There's a huge variety, but even the same GMSCS level, even if, let's say, take a particular task is equally difficult to two children, and they require the same amount of assistance to accomplish that task. For one child, they may say, I don't care, this doesn't bother me. I'm perfectly happy to use a wheelchair. I can keep up with my friends with a wheelchair. You know, walking, schmocking, it's not important to me. Another child, on the other hand, might say, you know, that is important to me. And so, in which case, a questionnaire like this, by identifying what's important, we will then be able to tailor our discussions. So for the first child, I shouldn't be talking to them about multi-level orthopedic surgery or a spine operation to help them walk better, because for them, it's really, they're not so concerned about being able to walk, or they're happy with the way they walk. For them, it's more important to get from A to B as efficiently as possible, and they're happy to use a wheelchair to do that. But it may not be the case for somebody else, who maybe because of their personal circumstances, they live in an environment where there is very little wheelchair access, for example. So having to walk becomes a very important function if you want to get around. Or it may be very important to them. And for them, of course, we should tailor our interventions to try and address that priority. So it's exactly to address the point that you made, that given the same problems, different people may say that's important to them or less important to them.
Okay.
Does that make sense?
Yes, it does. Thank you.
Unni, if you have one more moment, we have one final question.
Yes, of course.
Do you have one more moment? Okay, yeah. Connie, go ahead.
Thank you. So I'm at Seattle Children's Hospital, and we've been using the outcome measures for a little while. And so I'm super excited to know that the e-version is coming up. And I'm just wondering how long you view that before it might be public. And then the other question I had is, I've been really surprised when I look at some of the children when they fill out these, like how they view what's difficult versus how difficult I view it for them, and having those conversations. And I also have heard from parents that they're surprised when they answer a question like, oh, that's not that hard, but it takes them, maybe it takes them 10 minutes to do something that we view as more difficult. And I wonder if in your study, are you guys looking at both our parents and children, if they're able to fill it out? Are you gonna be looking at both?
Thank you, Connie, absolutely. So we have just completed the analysis of a large group of patients to compare patients and their parent responses. And what we've seen, and this is fairly consistent, parents consistently rate their children worse than the children rate themselves.
Yeah.
And I would bet you rate them worse than the parents rate the children as well. And this is because, you know, we don't, for the child, this is their life. They know what their life is, and this is their normal. We will impose on them what's normal for us or normal to a sibling or to a typically developing child. And so we impose our value system on that child. So those, but we also found that there's a very close correlation, by the way. Parents and children are very closely correlated, but consistently the parents are down here and the children are up there, you know, across the questionnaire. But there are individual items where parents may say this is something very important to them, and it may very well be, but not so important to the child. And some things are more important to the child and less important to the parent. And this is why it's really critical whenever possible to get the child's perspective, but we can't ignore the parent's perspective because they have a longer view, and so it's important to consider both. And just by doing that, it's helpful, you know, to get them talking to each other about what's important, and it really is part of that shared decision. It's not just between doctor and patient, but it's doctor, patient, and parent, all of us.
Thank you.
And Connie, let me just add one thing, which is independent of the analysis as to whether or not it improved shared decision-making, the goal and CPCHILD are actually being built into Epic and will probably be available in Epic right about the time you guys go live in Epic. So, and then you're doing your CP implementation after that. So they'll be available to you with some of this same kind of reporting and whatnot, because a lot of clinicians are using them independent of whether or not they find them a good measure of shared decision making, but just as a good way of getting insight into as to what's important to the patients and patient families and whatnot. So,
and Connie, I'm not sure if you're part of the group that has been in touch with me to do a presentation online with Seattle Children's.
Yes.
And I apologize, it's been crazy, but I will get back to you about that. We can talk more in detail.
No worries.
Seattle Children's has actually been in touch with me, separate from you guys, because they're interested in adopting CPCHILD and the goal, and they're working with a particular vendor to create the electronic versions. I haven't heard from them recently, but there is work going on in the background from Seattle Children's, so we'll find out soon enough. But I'll be back. I will be in touch with you separately.
Excellent. Thank you.
Okay. Well, let me say, Unni, thank you so much, in particular for your passion about this whole area as a parent of a child with cerebral palsy. I think having clinician researchers that view taking our input, understanding the child and what's important to them and what's important to families is so critical. So thank you for your passion about this and your work in this area, and thanks for your presentation this evening.
Thank you, Paul. I feel very privileged to be part of this, and I'm very grateful for you organizing this and for all the input from all of you out there. And I'd welcome any additional feedback you have about this. It's really important to know what you think and whether this is really going to help in that way.
Great, thank you. And anybody who had questions that you didn't get to answer, you can ask them on MyCP and we'll get them answered there. So thank you all. Thank you, Unni.
Thank you.
Goodbye, everyone. Good night.
Thank you.
Distribute my email address for anybody who wants to get in touch with me if they have questions. I'm happy to answer.
Okay, I'll take care of that. Thank you, Unni.
Okay, bye everybody. Stay safe and well.
You too.
Yep. Bye.